All right, I have the top of the hour, so I'm going to go ahead and get started. So I just wanted to say hello and thank you for everyone joining us on today's webinar. We are here to talk about patient safety. This event today is being recorded. The link to where the recording will be posted will be sent in an email following the completion of the webinar on Thursday. My name is Caleb Lozinski with the National Rural Health Resource Center, who is providing this webinar today. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, press *6 to unmute your line. You can also communicate through the chat box, which is located in the bottom ribbon in the middle of your screen. If you haven't seen it already, people are typing their name, title, and organization into the chat box. If you haven't already, it would be much appreciated. It helps us get a good feel of who is on the webinar today. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the TA provider for the Delta Region Community Health Systems Development Program. The Delta program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You may learn more about our website. You may learn more about this on our website. As Kate previously mentioned on last week's webinars, we do have the summit coming up in September. If you have not registered for that, please reach out to me and I will get you the link. The last part in this quality series takes place this Thursday, August 1st, where Sarah and Carla will focus on health equity and population health. As always, we have our wonderful Sarah Brinkman and Carla Wang on today's webinar. I will go ahead and turn it over to them, but before I do, I'm going to go ahead and launch the pre-polling questions. We will launch the same questions at the end, and it helps us get a good feel of the knowledge gained on today's webinar. Carla, Sarah, thank you so much for being here.
Thanks so much, Caleb. Carla's going to get the slides pulled up here. We're excited to be back with you again for week 2. For those of you who maybe were not able to join us last week, I know that you will have access to the recordings from those presentations, and we encourage you to check those out. Today, we're going to be focusing on patient safety, and then on Thursday, if you're able to join us, as Caleb mentioned, we'll be digging into health equity. A little bit about where Carla and I are coming to you from. Stratus Health is a longtime partner of the National Rural Health Resource Center. We are an independent nonprofit that works at the intersection of research, policy, and practice to lead collaboration and innovation in healthcare quality, safety, and equity. We have a long history of working with rural providers and really enjoy any opportunity that we have to get in front of an audience like this. So thank you for having us today. That's us again. I feel like we're in here too many times. Okay, so if you were here last week, you know the drill. Your participation is key. We have some kind of more formal didactic content to share with you, but a lot of what we are hoping to get out of this is to hold space to really bring forward the knowledge and expertise that you all have to be able to share with one another. So Caleb has already invited you to introduce yourself in chat. If you have the ability to update your name so that we can see how you would like to be referenced. Sometimes it's first initial, last name when you log into Zoom. And so it's not always easy to identify who's raising their hand or who's speaking up. The way that you can do that is in your participant list. There's a little 3 dots next to your name. If you click on those 3 dots, you can rename yourself. Caleb's already offered the opportunity for you to participate in a poll. So we hope that you'll complete that poll as well as the one at the end. We'll have some chat prompts, and we will also be opening it up for group discussion. So we did send out the questions for today's session and Thursday's session in advance. They are in the calendar invites that you have for today and Thursday. These aren't meant to be, these aren't trick questions. This is meant to be conversational. So Carla today is going to go through a lot of great content related to patient safety, and particularly how it aligns with 3 of the 9 core elements of quality infrastructure. And we want to hear from you about what resonates about the examples that we give, what that looks like in your facility, and really, again, be able to hold space to bring forward the knowledge and expertise in the room. To get us started, this is a very, very easy, pretty straightforward question. It is hot. You all are in the Delta region. I'm in Minnesota and I'm hot, so I know that you all are probably hot. We want to know, what is your favorite way to beat the heat? So you can weigh in the chat. If you'd like to unmute and share, feel free. There's some examples here on the slide. But would just love to see some answers from folks. What's your favorite thing to do when it comes time to really beat the heat? Of course, air conditioning is essential. Getting in the pool, ice cream, oh, water parks, very fun. The river, excellent. These are all fantastic examples and ideas. So thank you for humoring us and participating in kind of a fun intro icebreaker. I'll be making a list of things as we go into August with kids, ideas of things that we can do through the remainder of the summer. Just a little bit of another reminder of where we've been and where we're going. So this is a 4-part series. Last week, we covered in session 1 the core elements of quality infrastructure. We're going to talk about that a little bit more again today to offer some context, especially if you weren't able to join for that first session. Encourage you to go back and check that out. And then on Thursday of last week, we did a dive into patient experience. Particularly, we talked quite a bit about HCAHPS, the Hospital Consumer Assessment of Healthcare Providers and Systems. But we did talk about patient experience in the broader context as well, and really explored that through the lens of 3 of the 9 core elements of quality infrastructure. And today, July 30th, we're going to dive into patient safety, taking a different 3 of those 9 core elements and diving into the application of how you can think about what that means for patient safety in your facility. I think with that, I'm turning things over to Carla to get us started.
Hello, everyone. So what we're going to do today, we're first going to start out by talking a bit about sort of trends in patient safety, in particular, some changes and really an increased focus that we're seeing coming out of CMS in terms of some of the Medicare quality programs that I think have an influence on what gets measured, where things get focused on, those types of things. So we'll do sort of a high level trends, what's happening coming out of CMS, and then we're going to dive into those opportunities that align with those core elements we've been talking about. So today we're going to talk about organizational strategic plan, behavioral standards, and then collecting meaningful and accurate data. So 3 of the 9 core elements and how they particularly apply to patient safety. So we're going to dive in with a little bit of a history lesson. For many of you, it might feel like ancient history. I actually lived through this. I started at Stratus Health in the year 2000, right as the To Err is Human report came out, which really was I think we're still talking about it almost 25 years later. And it really was a groundbreaking report that highlighted the amount and type and number of medical errors that were happening in our healthcare system. So at that point, they outlined that 98,000 people a year were dying because of medical errors, the equivalent of multiple jumbo jets, and yet nobody was talking about it. So this report really started everyone talking about it. And patient safety has been, I think, a forefront ever since. So not that people didn't talk about it before that, but this really kind of supercharged that discussion. So that To Err in Human really kind of laid out all the flaws and the challenges and the issues. The next report that followed from the same group was called Crossing the Quality Chasm. And this is really the solutions, like where do we go? What are the policy recommendations? Where do we go from here? And honestly, even though it is now 23 years later since this report was released, it's actually still quite very relevant. I think that speaks to the timeliness of it, but I also think it means that we have continued opportunity. So this report, for example, is the one that gave us the definition of quality, that it's safe, timely, efficient, effective, equitable, and patient-centered. So I have used that definition of quality in probably 100 presentations, and it still rings true today. Those words still matter, and we have had different focuses on all of them. It also laid out kind of a variety of recommendations. So one of the primary recommendations was that we really acknowledge quality and safety as a system property. So we've been talking about that in terms of infrastructure, that we have healthcare workers who go to work every day intending to do the best they can to care for patients, but we have flaws and opportunities in our systems that let them down and let our patients down. So how do we focus there? It also identified that we need commitment by healthcare organizations at all levels to focus on quality and safety, which is a lot of what we'll talk about today, aligned with those core elements as we're focusing on quality. And then the other piece that it laid out is that there really should be federal funding that'll focus on monitoring, tracking, and evaluating progress towards those aims. So I have to tell you, and this is perhaps where the history lesson comes in. When I started working at Stratus Health, I worked with all of the hospitals and clinics in the northwest part of Minnesota, which is quite rural. And I used to go out and I would visit them to talk about quality. And I would offer somebody from our staff could come out and abstract charts for them to get a feel for what their heart failure, pneumonia, and AMI quality metrics might look like. They would go on site, we would do it for you. And I had a lot of hospitals turn us down. At that point, there was no public reporting of quality data. There was no reporting of quality data at all. The Joint Commission had just started to lay out their ORIX program. So Joint Commission hospitals were just starting to report kind of a baby set of measures. So clearly, for those of you that do any sort of hospital reporting, that landscape has changed dramatically. So we're going to talk a little bit about some of those policy influences as we talk about what's happening in patient safety. The other piece that I wanted to highlight for you, and I hadn't actually dug into the report for a while until I was preparing for this presentation, and it just struck me that there are 10 rules for redesign of care that were laid out in that report are also really quite relevant today. Care based on continuous relationships, customization based on needs and values, focusing on the patient as a source of control, shared knowledge and free flow of information. We talk about that a lot in terms of health information technology and how we get the right information to the right care providers at the same time, that the patients know what's going on, how we look at systems, transparency, focusing on waste and cooperation among clinicians and coordination. So all still really relevant kind of aspects as we're thinking about what's needed as we continue to redesign care. So I wouldn't like to say that nothing has changed because a lot has changed in that time frame, but we still have a lot of continued opportunities in patient safety. So I just pulled a couple of examples from different reports for you because it's a bit overwhelming if you start to dive into all of the data. So the first one I wanted to highlight was actually out of the British Medical Journal. It was a meta-analysis that was done in 2019. So this is pre-COVID, and identified at that point that as many as 1 in 20 patients continue to experience preventable harm. So we still have those opportunities in our systems to improve patient safety. The other three that I highlight here are all sort of in kind of mid to kind of, I don't know if we're ever post-pandemic, but kind of later in the pandemic. And one of the things that they have recognized as you start to look at the data is that the stresses of the COVID-19 pandemic on our healthcare system really have eroded some of those gains toward patient safety. So we're still seeing that 25% of Medicare patients experience harm and that about 40+% of those events are judged to be preventable. So medication errors, pressure ulcers, surgical procedure errors, infections, all those things are continue to be opportunities where we need to consider and focus. And that country is still at a relative standstill in patient safety. So what we're seeing out of sort of this is now CMS is really starting to use their regulatory authority, their levers of influence over the healthcare system to kind of refocus on patient safety. So I want to share just a couple of pieces with you around where CMS is going related to sort of quality measurement and particularly related to patient safety. So last March, so about a year and a half ago now, CMS came out with this article called Aligning Quality Measures Across the Universal Foundation. So we went from essentially no quality measures being reported anywhere 25 years ago to hundreds of variations of quality measures being reported all kinds of places. So I would say for the last maybe 10 years or so, there have been a variety of conversations around harmonizing quality measures, finding a parsimonious set of aligned quality measures. Like, how do we make sure that we're measuring the right things, but that we're doing it in an aligned manner, so everybody's not trying to measure things differently. I don't think we're there yet. I think this is aspirational, but it is, in the years I've been doing this, I find it optimistic because it's not just that they said we're going to try to align quality measures, but they said, here's the measures. These are the measures that we're going to try to focus on CMS programs. And I know the list is tiny. This isn't where I wanted to focus, but I just wanted to give you a sense is that most of these measures are more around population health. So wellness and prevention measures around breast cancer and cancer screening and immunizations, around controlling chronic conditions, addressing some behavioral health issues. We do have some all-cause readmissions pieces, and certainly person-centered care as measured by kind of that HCAHPS or the consumer, that CAHPS set of surveys. They also have called out sort of looking at social drivers of health and identifying those, but really not particularly safety related measures. So this is the base set. CMS has said, here's the universal foundation that as we're building out programs, particularly aligned with some of their payment programs, we're going to try to get alignment across these measures. But they've also recognized that we need sort of add-ons for specific types of settings. So the add-on for hospitals is really patient safety focused. So this is the measures that they're saying are important for hospitals. For those of you that are critical access hospitals, I have the related Medicare Beneficiary Quality Improvement Program, or MBQIP measures, in bold. So they want to look at hospital-wide risk standardized mortality and screening for social drivers. They're saying that that's related to chronic conditions and equity. Patient-centered care, we talked about a lot last week. But look at this whole set of safety measures. So we have a whole bunch of measures around hospital-acquired infections. We have measures on the patient safety indicators. There's the 90, that's something they calculate based off claims and sort of never event type things. Sepsis, severe OB complications. So really leaning in from a CMS perspective on measures for hospitals in particular that are related to patient safety. And that's only a starting point. So there is a whole process for those of you that are responsible for quality measures, you probably notice that they sort of change on a regular basis. And most of the quality measures that we reported up through CMS and through other federal programs are sort of dictated but through an annual process of rulemaking. So the inpatient quality measures are part of the inpatient prospective payment system rule. So that's how they define and add and remove quality measures, is through that annual rulemaking process. The outpatient measures are through the outpatient rulemaking process. The measures for quality payment program are through the physician fee schedule annual rule. So thousands of pages of annual rules that come out every year, ask for comment, and then CMS takes that comment and finalizes them. So they had several patient safety related measures in this year's proposed rule. So these are measures that are proposed at this point. We'll find out later this fall whether or not they're final. So the first one that I wanted to highlight for you guys is a new patient safety structural measure. And this is where hospitals would actually go in and answer a set of questions attesting to the fact that they have certain evidence-based best practices in place. And what we're talking about in terms of these attestation areas is really aligned with what we're talking about in terms of core elements of quality. Do you have leadership commitment in place? How are you thinking about strategic planning and organizational policies related to safety? What's your accountability and transparency and culture and patient and family engagement look like? So this will be an opportunity, assuming that it makes it through the proposed rule, to really start looking and assessing from a kind of structural standpoint what that looks like in terms of patient safety at your organization. So I do have links to all of these details in the slides. So if you want to dig more, we can help you get that information. So that's one of the new measures that's being highlighted. The other place that we're really seeing a lot of patient safety measures is related to the electronic clinical quality measures. So for PPS hospitals, that's both part of the inpatient quality reporting program and the promoting interoperability program. So critical access hospitals are not held to the inpatient quality reporting requirements, but they are held to the promoting interoperability requirements. So I have another slide on kind of those measures after this, but I just want to highlight that if you're a critical access hospital, the ECQM requirements do apply for you. So these are two new measures that they are proposing to be starting in a calendar year 2026. So one is related to hospital harm, focusing on falls with injury, and the second is around post-operative respiratory failure. So more details on that at this link here. A couple other new measures that they're proposing for if there's any of you that are providing cancer services. So the catheter-associated urinary tract infection or CAUTI measure and the central line-associated bloodstream infection, CLABSI measures are not new. What's new here is that at this point they're being called out separately for oncology locations. So if you are providing oncology services, those measures are going to be reported for your oncology locations separately than for your broader hospital. And then they are respecifying a measure that's focused on the 30-day risk standardized death rate around surgical inpatients with complications. So that's a claims-based measure. It's not something that hospitals have to report on. It's something that CMS uses claims data to calculate. But I do want to call out for you that for all of the claims-based measures, at this point, they are predominantly calculated just using Medicare fee-for-service, so your traditional or your original Medicare patients. But we know even in rural communities that we really have a rapidly growing percentage of Medicare beneficiaries who are on Medicare Advantage products. So to date, they haven't included Medicare Advantage in those claims-based measures, and they're starting to get them incorporated. And this is one of those measures that will be on the early edge of that. So this is similar to a previous measure. It's claims-based, but it's now going to also include Medicare data on Medicare Advantage patients. So here's the piece I wanted to really, when I look at kind of what CMS is doing with rulemaking, this is the piece that really tells me that they are pressing down on this accelerator quite hard. So the Promoting Interoperability program has a variety of requirements. One of them is reporting of electronic clinical quality measures. And CMS has been kind of progressively increasing that number. But what they have proposed here is really taking what's right now kind of only a couple of required measures. So currently, safe use of opioids was the only measure that was required in 2024. Otherwise, hospitals could select from a menu. And shifting in a couple of years to essentially making all of the hospital harm related measures as required. You would still pick some of the optional measures and report on those, but really shifting so that anything that's related to hospital harm becomes a required measure for all hospitals to report. So that's a fairly significant departure from what that program has looked like currently. Another piece where we see them really leaning in on the patient safety component is that currently under Promoting Interoperability, hospitals have to attest that they've done annual assessments using the SAFER guides. You don't have to attest that you have all of the components that are outlined in those SAFER guides. You just have to attest whether or not you did it. Now you actually have to say yes to that you've done that assessment and that they're also in the process of updating those SAFER guide assessments in early calendar year 2025. So if folks aren't familiar with these, it might be worth taking a look. I'd also make sure that you have your HIT or your IT directors as part of these conversations because they're really leaning in on the IT component of this and how our systems around our IT systems kind of help provide safer care. And then the last update in that measure, proposed update that I want to share is related to what they call the public health and clinical data exchange objective. So connected to patient safety in terms of kind of how they're looking at antibiotic use and resistance. So what has been passed currently is that there says that you're required to report an AUR surveillance. So they really kind of linked them together. In my mind, this is actually a clarification of a previous rule because what gets reported for this is actually two separate things. It's antibiotic use and antibiotic resistance. And how you report those is slightly different. So CMS is proposing a clarification on what that looks like as well. Okay, that's a lot. It's a lot of regulatory stuff. It's a lot of maybe we think most of these things are going to happen. So I am going to pause and see if folks have questions about sort of this where CMS is going, or sort of that historical lens around patient safety in terms of what's happening from a quality reporting and quality measurement standpoint.
Carla, this is Sarah. I have a question to clarify. So we know that the AUAR, it's AU and AR, and for a while it's been AUR, which is a little bit of a misnomer. So with the shift to splitting them, if a hospital has the ability to report one and not the other, is the expectation, and before it was if you were exempt across the board.
Yeah.
Do we know what that exemption status looks like in terms of preparing if you have the ability to report on antibiotic use, but don't have the requirements necessary to report antibiotic resistance? Are you expected now to report antibiotic use?
Yeah, so that's that exclusion here. If you don't have the data source that has the elements that can allow you to do so, there is an exclusion.
And it applies across both of them? Does my question make sense? Sorry.
I believe they anticipate it will largely be related to the antibiotic resistance component, but I don't have that level of detail on hand.
Okay.
Yep.
We can dig into that.
Yep. Any questions about those proposed measures, proposed changes? Are these the electronic clinical quality measures something folks are looking at, thinking about? For a long time, electronic clinical quality measures were sort of a straight up IT exercise. Can you get the data out of your system and into the CMS system? They didn't get reported anywhere. Publicly, CMS has said that they're going to start publicly reporting those measures, although at this point they are not available on Care Compare. They're just available in the public use data files. Okay, well, if you have questions, jot them in the chat or feel free to contact me after. There's a lot of changes that are proposed, and we should find out, usually it's September when the final rule comes out. I would say on balance, CMS tends to adopt nearly everything that they propose, but not always. And sometimes they'll maybe make changes around sort of the timeline or some of those types of things, but they generally adopt most of what they propose. Okay, so let's shift back to the core elements of quality infrastructure. So we thought that patient safety landscape was sort of important to understand how that fits in sort of the regulatory requirements, particularly for hospitals. So there aren't as many reporting requirements related to those of you that are clinics that really connect patient safety. And a lot of times when we talk about patient safety, I think we actually really focus in on hospitals because of the level of care and the level of risk that comes attached to that. But there are really some opportunities to focus on patient safety at a clinic level as well. So Sarah's going to drop a resource for you guys, for those of you that are clinics, that I'd encourage you to think about. When we think about patient safety at a clinic level, it's oftentimes maybe more around potential for adverse drug events, potential for kind of loss or missed follow-ups. So there was a referral to a specialist. Did that actually happen? Lost or missed follow-up in terms of test results, miscommunication types of pieces versus less often about sort of actually like maybe surgical errors or hospital-acquired infections, that type of thing. So for those of you that are from a clinic setting, patient safety is still important. It just sort of takes a little bit different frame. Okay, so let's talk about how these core elements come into play. So if you were on last week, we first reviewed all 9 of these, and then we're taking turns sort of highlighting on each of the sessions, 3 of them a little bit more in depth. So today we're really going to focus on this middle trio, talking about quality embedded within the organization's strategic plan, culture of improvement through behavior, and then collecting meaningful and accurate data. So I want to connect you back to what is one of my favorite resource toolkits out there. It's Leading a Culture of Patient Safety. It's a blueprint for success. It is a free download, but you have to log in. So you have to create a login to download it. But it's a fantastic resource. It's not kind of filled with checklists and links and all sorts of great information that really sort of aligns with a lot of what we're talking about core elements. So is there vision? Is there respect and inclusion? Is your board engaged? Leadership, behavior, culture, all these pieces tie together regardless if you're focusing on patient safety, if you're focusing on patient experience, if we're focusing on equity, which we'll talk about on Thursday. But this one really leans on the patient safety side, focusing on zero harm to patients, family, and the workforce. And that is definitely something that I think we have seen more attention to, rightfully so, in the last 3 to 5 years, is that certainly patients should expect to be safe, but we also have to have expectations and processes and systems in place to ensure that our staff are safe. So how do we kind of connect that all together? So going to a link through, talk about some of the key resources that connect to this as we talk about each of these areas of quality. So the first one we're going to highlight today is really thinking about how quality is embedded in the organizational strategic plan. So that helps ensure that quality leaders participate in organizational strategic planning, that it's a core component of the strategic plan, and that it's reflected in all components of the strategic plan. So one of the ways we encourage people to think about this is if you look at the board agendas or the board notes for your organization, is quality on there? And is it actually not just a checkbox at the bottom? So what is kind of the focus? How does that connect to what's happening? So from a patient safety perspective, some of the strategies outlined in the blueprint are really around establishing a compelling vision for safety, board engagement, and leadership development. So I'd say one of the critical ways that we encourage people to consider engaging their board and or their leadership is to actually have patients who have experienced an error or experienced harm share their story with your leadership. There's nothing that, I mean, you could see all the data in the world can be powerful, but patient stories and family stories really make a difference in terms of helping people recognize and think about what this looks like. So we really want all of those things for our own care and our family's care, but it's really important to highlight, and that's an opportunity with your board and leadership, is to try to, if you have folks who are willing to kind of share their story, that really can make a difference in terms of that engagement piece. So how do we have our clinical leaders as part of the vision statement and strategic planning? How do we have sort of input from patients and families? How do we ensure education to our board about the importance of safety, the meaning of quality and safety, what those measures are? How do we have adequate agenda time for review and discussion of safety metrics? So it might be on the agenda, but is it the very last thing and you always run out of time? Or is it really kind of incorporated and threaded through as part of a focus? How do we think about organizational leadership competencies that support all of this? And how do we ensure that executives can articulate how a culture of safety applies in their department? So lines right back up to kind of the focus areas we have around thinking about quality infrastructure is how are our leadership and our strategic planning engaged, and how do we ensure that folks have the tools and the mechanism to be able to support that effort? Okay, so what does this look like at your organizations? What does it look like in terms of engaging your board in patient safety? What does it look like in terms of goals that you have for patient safety? We know the expertise is in the room. You guys are all doing work in these areas. So we've tried to lay out sort of the aspirational, here's the components, but what does it actually look like? So I encourage you to either chat in, come off mute, either, whatever you're comfortable with, but would love to hear from you about what this looks like.
Maybe a more pointed question to get us started is, does your organization engage your board in patient safety? So if the answer is yes, how are they doing it? And if the answer is no, maybe how might you think about beginning to integrate that?
Yeah. And thank you, Kelly. You noted in the chat that you share success stories with the board at each board meeting. What kind of success stories? What does that look like? We have one of you that has a daily safety huddle to discuss patient safety. So does findings from that huddle or things that get identified in that huddle, is there a mechanism for that to get shared with leadership or incorporated up into what happens with your board discussions? Ah, so you do a video of patients when they would like to share a great experience at the hospital. Nice. Do you also ever have conversations about people who perhaps had an error or a patient safety concern? Those are a lot harder than somebody just gushing about how great their experience was, right? But they're also, I think, critical in terms of helping focus. Okay. So leadership's included in the daily huddle and it's recorded and shared with all staff. Excellent. Ah, okay. Thank you, Kelly. So you do have sort of medical errors also get raised as part of those conversations and then how you addressed it. And Todd, thank you. Board member attends quality meeting and reports to the board meetings. I brief on the board on complaints monthly. Good. Do any of you have kind of bold goals or goals at all related to patient safety that are part of the kind of dashboard or quality metrics that go to your board for discussion and review? I know particularly the hospital acquired infection measures, although really, really important, are oftentimes challenging for hospitals with small volumes because of the way they get calculated. But are there other kind of patient safety related measures that you focus on and get shared with leadership or the board? All right, well, folks are thinking about that. We're going to move on to talk about continuous improvement through behavior. So this is really, I feel like when we talk about patient safety and just culture are two words, two terms that are linked together really closely. And just culture really is a way that kind of helps us think about and look at accountability in terms of behavior and how we're kind of structuring that. So this is a really aligned in terms of thinking about what our patient safety practices are. So a culture of a continuous improvement has the organization monitoring adherence to practices like evidence-based protocols. It helps encourage organizations thinking about relationships with external and internal and external, partners, particularly those at the local, state, and federal levels. That helps you think about and provide support. So currently it's the hospital quality, HQIC, Hospital Quality Improvement Contractor Program. Previously it was known as the HIN. There are resources that CMS puts out between that and the quality improvement organizations that provide support. There are resources at the state level that come through CDC that focus on patient safety as well, particularly around sort of the hospital-acquired infections and antibiotic stewardship, focusing reporting. So our organization's intentionally kind of engaging with those resources and opportunities for technical assistance support. How are you thinking about employees demonstrating initiative and to achieve and strive for excellence? We've shared before that one of our favorite quotes that came out of the summit that we put together for the core elements was that, how do you have people own their job instead of rent it? Because if you own it, you see the opportunities and you're much more willing to kind of make those changes and improvements. And then how do managers and leaders evaluate behaviors to ensure that they're in alignment with organizational values? So in particular, what this can look like when we're talking about patient safety is what are the safety behavior expectations, as well as organizational response to disrespectful behavior and conflict. So one of the most commonly talked about areas here might be, for example, barcoding for medications. If that's available, what is the expectation? What happens if folks aren't following the expectations? That one's had a lot of press in a variety of ways to think about at what point is it risky or unacceptable behavior. How you think about disrespectful behavior and conflict, also super important. We talked about that a little bit when we talked about patient experience, because the culture and the environment and how your staff react and work together reflects across the board in terms of the experience your patients have and in terms of how safe they are. So one example from here is that they actually require annual signatures from board members, leaders, and the workforce that help define those expected professional accountability behaviors. So making it very clear and updating it on a regular basis. It's ensuring that employees are well trained in teamwork and communication and supporting them in terms of those processes. How we think about clearly communicating and enforcing those behavioral standards. And this is both for clinicians and for staff. And then recognizing and rewarding individuals and teams for demonstrating positive safety behaviors and reporting. So we have some kind of making sure we're clear on what the expectations are, how are we going to hold people accountable to them, but also recognizing and rewarding. So kind of lining all of those components up. So what does this kind of area look like in terms of your organization? Do you have structures where you recognize staff achievements, particularly related to patient safety or patient safety reporting? Or what kind of communication or training or tools does your organization use to support staff in promoting patient safety, whether that be teamwork or communication strategies, any type of sort of aspects related to patient safety? So what are you thinking about in terms of staff recognition, and what kind of tools or training are you using? I think it's always super helpful to hear from peers about how they're approaching these areas. So I encourage you to raise your hand or just come off mute or weigh in on the chat with these questions, thinking about staff achievement, recognition, and then communication tools or training.
Does anyone have a close call program? Where you,
close call, near miss.
Yeah. Encourage, it can often align with a kind of the concept of just culture, to encourage folks to bring forward issues as they identify them, not in a punitive way, but in a celebratory way, because then you can learn from them and adjust. I know that there's lots of hospital associations that support near miss or close call projects. So curious if anyone is participating in one of those more broadly, or if you've implemented anything like that in your facilities.
All right, in the chat, Nicole says, we use a system called SQSS, put all the information into the system, and we use the near misses as education. We also talk about these at our morning safety huddles. Nicole, do you have any sort of highlighter recognition for folks who enter information? I think there's kind of a multi-layered components oftentimes with this. So it's one is having the system in place, which is fantastic. And then the second is whether or not people are using the system. So a lot of times we see that's where some of that recognition piece comes in. So it's industry, okay. Thank you for sharing a little bit more about that. Others who have sort of reporting systems processes or how they help kind of encourage or recognize staff for engaging in some of those patient safety related activities. Okay. Next element we're going to talk about is collecting meaningful and accurate data. So really hard to know where you're at if you're not actually looking at quality metrics and thinking about how that data gets captured accurately. And I would say some of those reporting systems, like Nicole just mentioned, are part of data collection and collecting that meaningful and accurate information. From a broader perspective, when we're thinking about quality infrastructure, it's really helping organizations think about what are key quality metrics. So there's a lot of data that can be and is collected, but sometimes we need to kind of pause and think about where are we going to focus. So what is required to collect and report? What is additional information we need? How are we kind of managing that flow of information and thinking about key quality measures? How do leaders identify risks and opportunities based on those performance measures? So I'm sure as you're thinking about, especially sort of that safety reporting system, that's going to help you think about what are common themes that we're hearing about. How are we thinking about risks and opportunities aligned with that? How do we leverage our health information technology to support complete and accurate data collection? For some folks, that works quite well. For some folks, that's an ongoing challenge, depending on the electronic health record that your organization is using, the amount and ability you have to customize or make edits to that, how your processes flow in terms of getting that information captured. And then as we think about both quality and safety, also whether or not you're collecting or documenting some of those patient characteristics such as race, ethnicity, and language, sometimes called REL data, sexual and orientation or gender identity, sometimes called SOGI data, or the health-related social needs data. And those are kind of characteristics that help us think about and particularly consider if we're going to stratify and look at different groups of populations and whether or not we're seeing any disparities or inequities in the care that's being provided. So what this looks like from a patient safety lens, if we think about meaningful and accurate data, it looks similar. So thinking about working with the board to help set direction, goals, and metrics. How do you focus on that sort of that accountability to zero harm for both patients and the workforce? How do you think about disparity metrics and how they're displayed in terms of what you're looking at for patient safety? And then thinking about safety and culture measures. Does that make sense to have demographic variables? Are you thinking about what's important to the community, how that aligns back to the community that you're serving? How do you think about patient safety culture surveys are a common mechanism that a lot of organizations do every couple of years. How are you using that information? How are you tracking on it? How are you using that to help make decisions and address challenges? And then, of course, we have to comment that we know the ability to do all these things assumes capacity of your systems, both technology and human, to have the capability to accurately collect that data and information. And we fully recognize that that is oftentimes not a minor lift. So we do have resource fee there around improving data collection across the healthcare system if that's one area that you're particularly challenged with. So if we think about what this might look like at your organization, Are you stratifying any of your measures related to kind of self-reported identity? Are you looking at things related to health-related social needs variables? If so, what have you learned? And if not, what's holding you back from doing those types of things? Do folks have a good handle and have the ability to get some of that measured data out of their systems fairly easily? Or is the process to get the data out and make it usable take up a lot of the air in the room? We know that that can be a challenge.
And remember that on Thursday, we're going to be diving further into health equity and talking more about some of the metrics aligned with health equity, including the new SDOH measures that CMS has put forth for hospitals, where we're collecting health-related social needs variables. I think often in patient safety, we think of individual events, and we're not always thinking at more of the of that kind of population health level for patient safety. And so if your answer is no, we haven't done this, and what's holding us back is we haven't thought to do it, or we that's a perfectly fine. I mean, that's an understandable answer. We're just curious to know where you're at and kind of queuing this question up a little bit in context of our forthcoming discussion on Thursday around health equity.
Yeah. And one of the reasons that some of this has come out, and it's the example I have in my head right now, it might not be the best because it's actually not a measure that's collected anymore, but there used to be a measure that was around timeliness to pain management for long bone fracture. So if you saw folks coming into your emergency department with a long bone fracture, how timely did they get pain medication? And part of the reason that that became a CMS quality measure was because when they looked at studies, they actually found that there was a huge disparity between people of color or who didn't speak English as a primary language and folks who were white and spoke English in terms of how long it took to address their pain in those types of situations. So that one came off the board in part related to issues related to opioids. So there's, all these things are multifaceted, but that's one of the reasons that I think it's so important to start to kind of pause whether or not it locally or from a bigger picture, more universal is, are there things that are happening that we might not even be aware of that are disparities in care, and how does that kind of influence what we're thinking about and capturing and looking at for data?
I think other patient safety related measures that maybe have close relevance would be thinking about maternal mortality and the disparities that we see in maternal mortality. We know that that the that the mortality rates for Black individuals is significantly higher in that space. And so that is about individual cases, and it's also about systemic issues that are leading to that being the case. And so how do we start to apply that lens, that equity lens, to patient safety concepts that we've traditionally kind of not veered into that space with?
All right. Any questions or other observations folks want to share? Any questions about some of what we shared regarding that's happening in terms of CMS and regulatory and measurement changes, or any observations or things that you think would be helpful for your peers to know about what you're doing related to patient safety, or questions for your peers to see if somebody else has got a process or a system in place that you might be able to learn from? Thanks, Kelly. Yeah, trying to improve transportation in your parish. That connects particularly when I mean, I've kind of focused on the hospital base, but when we think about more broadly about patient safety, missed appointments, missed follow-ups oftentimes are related to transportation. And so maybe the appointment was made, but somebody couldn't get there and then they fall through the cracks. So definitely related. Thank you for sharing that. And transportation home from the hospital, yes. Part of the, I think there's a fine balance between not wanting people to be in the hospital any longer than they have to, because that increases risk for things like falls and medication errors, but also making sure that they can get home and that they're safe when they get there. Yeah. Well, we will get to dig in with you guys today or Thursday when we talk about health equity. We do encourage you to take a look at those questions. They are included in the appointment. We really would love to hear from you guys. In the meantime, if you have questions or things that come up as you're thinking about this, please feel free to reach out. There are links to all of the information, particularly around some of the CMS proposed measures and changes. If you want to dig into those at all, there are links in all of the slides, so you can look at that a little bit more closely if you're one of the folks who are responsible for that kind of thinking about those measures and what that might look like in terms of reporting. And I see that Caleb has popped up the poll, so we will look for you guys to respond to that. And in the meantime, we will look forward to seeing you on Thursday.